When we see limitation of the eye movement, the key question is the muscle weak or is it the antagonist muscle which is mechanically tight? To answer that, we rely on two fundamental tests, the forced duction test and the forced generation test. Hello and welcome to Inside Ophthalmology. I am Dr. Amrit, and in this lecture from our Squint series, we'll understand these two important tests that play a crucial role in deciding surgical management in strabismus, the forced duction and the forced generation test. Let's understand the basic clinical rationale behind these tests. The forced duction test tells us if there's a mechanical restriction, something tight or fibrosed opposing the direction of the limited movement. The forced generation test, on the other hand, assesses how strongly the weak muscle can still contract, that is, how much force it can actively generate. In short, the forced duction test is a passive test and the examiner here moves the eyeball, whereas the forced generation test is an active test. Here, the patient moves the eye while the examiner resists and evaluates the strength. So we'll focus first on the forced duction test. Don't worry, we'll go into the depth of each of these tests. The forced duction test is also known as the traction test. It can be performed under local or general anesthesia. In children, we usually prefer general anesthesia. For adults, we can still instill topical anesthetic drops. The test is brief and only minimally uncomfortable. Now, the key principle here is to place the agonist and the antagonist in the right physiological state before testing. So for this, we ask the patient to look in the direction of the limited movement. This will ensure that the agonist muscle, that is the one that you are testing, is fully recruited and the antagonist muscle is stretched to its maximum physiological length before you attempt passive rotation. Okay, so it's important that you ask the patient to look in the direction of the limited movement. Once the patient is looking in the direction of the limitation, you gently grasp the globe near the limbus, about 2 mm from the limbal margin. This area will give you a firm grasp because the tenon capsule fuses here with the conjunctiva. Then you move the eyeball passively into the field of limitation. If you feel any resistance, it indicates that a mechanical restriction is present. The antagonist might be tight, fibrous, or there might be some orbital adhesion. On the other hand, if the globe moves freely, there is no mechanical resistance and the limitation is due to the agonist muscle weakness. It might be neurogenic or it might be a myogenic palsy. Let's take an example over here. A patient here has left eye esotropia and limited abduction. Now you ask the patient to look towards the left, the direction of the limited movement, to recruit the lateral rectus and also to relax the medial rectus by Sherrington's law. We know that Sherrington's law states that in any movement, the innervation, the positive innervation reaches the agonist, whereas the negative innervation or inhibition reaches the antagonist. Now, you hold the globe in the opposite side of the intended movement, that is nasal limbus, and attempt to abduct the eye passively. If you feel a smooth, unrestricted movement, it means that the medial rectus isn't tight. So the problem here is the paresis or the weakness of the lateral rectus. But if you do feel resistance, that suggests tightness or fibrosis of the medial rectus causing the limitation. Right? So a key clinical tip over here would be that if the patient does not look in the direction of limitation before you start doing the test, the antagonist will still be active and you will get a false impression of tightness. So always ensure that the gaze is properly aligned before testing. As I mentioned earlier, we usually grasp the globe about 2 mm from the limbus, but the point of grasp always lies opposite to the direction of the limited movement. For example, if abduction is limited, we are testing for medial rectus tightness. So we'll hold the globe nasally at the nasal limbus and attempt to abduct the eye. If adduction is limited, we are checking the lateral rectus tightness, so we hold it temporally. If depression is limited, we test the superior rectus by holding at the superior limbus. If elevation is limited, we test the inferior rectus by holding at the inferior limbus and try to elevate the eye. I hope that makes sense. The holding point is always opposite to the restricted direction of movement. An alternative technique is using a cotton tip applicator. The forced duction test can be performed using a sterile cotton tip applicator. For example, here's a patient with right sixth nerve palsy and limited abduction. So you apply the cotton tip applicator adjacent to the limbus, diametrically opposite to the direction of the limited rotation. So in this case on the nasal side, and you try to passively abduct the eye to assess restriction. Now, if you're using forceps and if you want to use both your hands or two forceps, you can hold the globe at 2 points placed perpendicular to the direction of limitation. So this is also one method. For horizontal restrictions, we hold the globe at 6 o'clock and 12 o'clock. And for vertical restrictions, we hold the globe at 3 o'clock and 9 o'clock position. Jempolsky suggested that when you are testing the vertical recti, it's better to place the eye in about 23 degrees of abduction to isolate these muscles. That's because elevation and depression are actually caused by two muscles. Elevation is caused by superior rectus plus inferior oblique together, and depression is via the inferior rectus and superior oblique. So testing in abduction isolates the recti more effectively, and that's an important clinical pearl to remember. Now that we have learned how to perform the test, whether using one forceps, two forceps or a cotton tip applicator, let's talk about the interpretation. We know the basics. Positive forced duction test means restriction is present and there's a mechanical problem. Negative forced duction test means the globe can move freely, that is neurogenic or myogenic weakness. But it's equally important to recognize different resistance patterns because they help you identify whether the restriction is focal, diffuse or secondary. So let's look at them one by one. The first one is the absolute restriction. Here there's a sudden immediate resistance to the passive movement. No matter how hard you try, the globe just won't rotate beyond a point. That means there is a mechanical or structural block like the tendon entrapment or Brown syndrome. Then there could be a uniform resistance. Here, the resistance increases gradually throughout the entire range of movement. This suggests a diffuse mechanical constraint, not a focal block, and is typically due to the muscle contracture or a generalized fibrosis of the muscle. Sometimes, however, you will feel initial free movement, but then a sudden tightness develops near the end gaze. This is known as the leash phenomena, and it represents a moderate contracture or fibrosis, and it is commonly seen in long-standing paralytic strabismus when the antagonist muscle becomes secondarily tight. Okay, so this leash phenomena could be actually of two types. It could be direct leash or it could be reverse leash. In the direct leash, the antagonist develops scarring and shortens. For example, after a lateral rectus palsy, the medial rectus shortens and limits the abduction. Reverse leashes when the agonist muscle itself becomes fibrotic, restricting motion in its own field of action. For instance, fibrosis of the superior rectus preventing upward movement. Okay, so that's a reverse leash effect. Same example has been shown here in this picture. So to summarize the types of resistance, we have an absolute resistance where you have a sudden rigid stop. Then you have uniform, in which there's a gradual rise in the resistance. And then there is a leash effect where there is free start and then there is tightness towards the end of the movement. When performing the forced duction test for the recti, remember they run anteriorly and insert near the limbus, so don't push the globe backward into the orbit. NAPS specifically emphasize that excessive retropulsion can create a false negative result. Pushing the globe too far posteriorly relaxes the anterior segments of the recti muscles and their facial tissues, and therefore it also relaxes the tension on the restrictive elements, if at all any present. So this can make a truly restricted globe appear to move freely. So be gentle, right? Avoid retropulsion during an FDT for recti. We'll see in a moment how this changes when we test the oblique muscles. Okay, so now let's talk about the forced duction test for the obliques. We have two oblique muscles, the superior oblique and the inferior oblique. If you are simply testing for restriction of the movement, the direction of the test is elevation in adduction for the superior oblique tightness and the depression in adduction for the inferior oblique. So what I mean to say is that the elevation in adduction would be restricted if superior oblique is tight, and depression in adduction would be limited if inferior oblique is tight. Okay, and a tight superior oblique is found basically in the Brown syndrome, whereas inferior oblique tightness can occur due to the fibrosis of the muscle itself. Now, an important variation of the forced duction test is the retroplacement of the globe or the retropulsion. You might recall that earlier I told you not to push the globe backwards because that can create a false negative result in rectus muscle testing. But here's the key difference for obliques. Retropulsion actually works for obliques. Think about the superior oblique. It originates posteriorly, passes through the trochlea, which acts like a pulley, and then it inserts superior temporally, slightly posterior to the equator. So when we push the globe gently backwards, we are actually stretching the tendon and its sheath, and that's useful. So let's talk about the exaggerated forced duction test, also known as the oblique traction test. This test is special because it not only detects the restriction but also reveals laxity of the superior oblique tendon if any present. Let's visualize this. Imagine you're sitting at the head end of the patient. The right eye of the patient is on your right and the left eye of the patient is on your left. When performing this test, for the right eye, you hold the globe at 4 o'clock and 10 o'clock positions using your fixation forceps. For the left eye, you hold it at 2 o'clock and 8 o'clock position. This grip will ensure that you are controlling the eye in the correct oblique meridian. And yes, the positioning will actually vary for the inferior oblique. It will actually be perpendicular to what positions are mentioned for the superior oblique. Let's see how do we actually perform this exaggerated forced duction test. So first of all, we are going to retropulse the globe. This is going to make the superior oblique tendon taut. Similarly, we are going to extort the globe and then try to do elevation in adduction. All these three maneuvers are actually going to increase the tautness of the tendon by increasing the distance between the trochlea and the insertion of the superior oblique. Okay, now at this stage, if the eye resists elevation in adduction, it means that there is a superior oblique restriction as seen in case of Brown syndrome. Next, what you do is you proceed to the fourth step, wherein you rock the globe nasally and temporally. That's called nasotemporal rocking movement. Okay, so basically on that taut tendon, now you're going to roll your eyeball up and down, or you can call it nasally and temporally, and feel for the tendon laxity. So normally as you roll the eye back and forth across that tendon, you should feel a small rounded resistance like a normal speed bump. Okay, this is the normal tendon slip as it glides smoothly through the trochlea. You will feel a gentle rise in resistance and then a smooth release of the resistance. But if the tendon is too lax, then the bump is going to disappear. So the motion will now feel too smooth, like there is no cable underneath. So that is known as tendon laxity. Okay. On the other hand, if the tendon is too tight, you're going to feel an abrupt knife-like stop to the elevation in adduction. Okay. So sometimes you might also feel or hear a click or a snap as the tendon catches in the trochlea. All these are findings of the Brown syndrome. So remember, in Brown syndrome, your forced duction test will be positive in elevation during adduction, and this forced duction test will become more positive as you retropulse the globe or retroplace the globe, right? So in short, in healthy normal tendon which is gliding through the trochlea will give you a speed bump like resistance, whereas in superior oblique restriction, as in case of Brown syndrome, you're going to have a knife like stop or click, and this difference becomes even more obvious when you apply retroplacement during the test, and therefore that test is known as exaggerated forced duction test. Remember, not every resistance means restriction. Several artifacts can mimic a positive test result. Let's go over a few that can mislead even experienced examiner. Some patients are simply too anxious. They will squeeze their eyelids or tense their vital muscles, what we call as the eye muscle guarding. Now this eye muscle guarding out of the anxiety creates an illusion of restriction, but it's actually voluntary tension, not a real mechanical block. So remember that. Moreover, the eye is richly innervated, so manipulating it too vigorously can stimulate the vagus nerve, causing pain, dizziness, and even nausea. So always be gentle. Keep communicating with the patient and stop if they feel uncomfortable. Now, in older patients, the conjunctiva is pretty fragile, so rough handling can cause tears and subconjunctival hemorrhage. Similarly, in young and in uncooperative children, a sudden eye movement can tear the conjunctiva since we usually use a tooth fixation forceps for a firm grip. That's why in pediatric or uncooperative cases, it's better to perform the test under general anesthesia. Now, while performing the forced duction test under general anesthesia, remember that the muscle relaxants can also alter your results. And if you misinterpret these effects, a normal muscle might appear restricted. For example, ketamine and succinylcholine. Succinylcholine is a short-acting depolarizing agent causing extraocular muscles to contract and stay contracted for up to 20 minutes. During this period, the globe feels rigid as if all the muscles are in spasm. So if you perform the test too soon, it can lead to a false suggestion of restriction, that is, a false positive test. So always with succinylcholine, wait 20 minutes after giving succinylcholine before you do your forced duction test. Ketamine also has a similar temporary effect. In contrast, the non-depolarizing agents like the pancuronium and vecuronium, they can cause flaccid paralysis without sustained contraction. So they don't distort the passive muscle tone, so they are preferred during the forced duction test. Even when your technique looks correct, small technical errors can alter the outcome. If you don't follow, for example, the muscle's natural arc of movement, you might get a false negative test because you're shortening its contact path. Conversely, pushing the globe too far forward, like proptosis while carrying out the FDT, artificially increases the tension and can give a false positive effect. Here I'm talking about the recti. Overstretching the tissues can also create a false impression of improvement. And not all restrictions are anterior, some of them can be posterior also, as what we saw in the reverse leash effect. Now, in some cases, the paralysis and restriction can coexist. This was highlighted by Kushner, and he found that the mechanical and the neurological causes can actually overlap. For example, in an orbital floor fracture, a muscle may appear weak, but the real problem might be both entrapment as well as paralysis. So when you see a restricted movement, don't stop just at the mechanical explanation. Restriction can also hide a weaker agonist, especially in thyroid orbitopathy or long-standing cases. If you don't assess both the components, you risk basically mistreating the condition. So the question is how to differentiate between the two. To separate the true paralysis from mechanical tethering, use complementary tests, basically like the forced generation test and the saccadic velocity assessment. The forced generation test basically checks whether the muscle can still generate an active pull, and the saccadic velocity measures how fast the eye moves. Okay, so never rely on a single test. The forced duction test tells us about the passive mechanics, while the forced generation test will reveal the active strength of the muscle. Together and in the right clinical context, they give us the true picture of the ocular motility limitation. Now let's discuss the forced generation test itself. Here the examiner resists the eye movement while the patient actively tries to move the eye in the direction of the muscle action. This helps us assess the contractile strength of the suspected paralyzed muscle. It's also done under the topical anesthesia. So you grasp the globe near the insertional suspected muscle. We already discussed those points earlier. Then you ask the patient to look in the direction of the muscle action and you feel for a tug on the forceps. So if you feel a tug, it means that the muscle still has some contractile strength. If you feel no tug, that means the muscle is either completely paralyzed or it has been detached. So this makes the forced generation test a very useful test intraoperatively, especially for assessing paralyzed or slipped muscles or lost muscles as well. So remember, the forced duction test is a passive test, forced generation test is an active test. Together they can help you decide your surgical plan as well. You always perform the forced duction test first. If the globe is moving freely, that means there's no restriction, or if the forced duction test is negative, then we proceed to carry out a forced generation test. And now if the forced generation test is negative, that means if the muscle generates no active force, you really can't strengthen it. So you'll need to transpose the force from another muscle, and that is known as a transposition procedure. So here's the simple flow. If the forced duction test is positive and the forced generation test is also positive, it means that there is just restriction which is present, and therefore you are going to weaken that tight antagonist limiting the movement, and weakening is done by recession. If the forced duction test is negative and the force generation test is also negative, it means that there is no restriction, and force generation test being negative means that the muscle itself also doesn't have any force in it or any strength in it. It is completely paralyzed. That means it needs force from outside, from another muscle. That means the muscle needs a transposition surgery. Okay, so before planning a transposition, make sure that the globe moves freely and the paralyzed muscle shows no contractile force. So we'll basically be discussing transposition in our future videos. So if restriction is felt first, always recess the tight antagonist before considering a transposition. And that's all for today. I hope you enjoyed this video and learned something new. Thank you for watching and supporting Inside Ophthalmology. We are trying to reach 100k subscribers soon. So don't forget to like, subscribe and turn on your notification so you never miss our upcoming videos. Thank you and have a nice day.